Today's midday YouTube video by Dr. Soloway is going to be on knee pain and osteoarthritis. All lunchtime videos are going to be about a patient I've seen the morning prior. So this morning, just had a discussion about knee pain. The patient was about 50 or 60 years old. Female, walking is her hobby. She came to me and said, I have knee pain for about 1 to 3 months. It's really not painful. I can't really describe it. It's a little bit vague. It feels a little bit heavy. It doesn't click, it doesn't lock, it doesn't snap, it doesn't give away, I don't fall. I think it started when I got out of the car, when I stepped on some uneven ground, or I might have rolled my foot one way or the other, but there was definitely no injury. So the first thing I start to think about is, what could this be? Is this just regular arthritis? Well, for those of you, regular arthritis is the good kind, or what we call osteoarthritis. Osteoarthritis is when the cartilage thins, often with aging, often from trauma, and the bones come closer together, and as the bones come closer together, the normal remodeling of bone becomes confused. So during the confusion, the remodeling occurs, but the bone doesn't know where to go, so you grow new bone. That new bone are called osteophytes. Osteophyte. Osteobone, phyte is new, like a neophyte is a new person. So the patient will develop the cartilage or joint space narrowing. The bones come closer together. By the way, the term bone on bone shouldn't be used because it's a fake term. It is a term used to tell you you must have knee surgery, which is not true. You don't need the knee replaced. I mean, sometimes you do, but usually you don't. So anyway, back to the patient and the evaluation and the description of osteoarthritis that I was giving you. So I asked myself those questions. Does this person have cartilage narrowing? Do they have narrowing of the joint space? Do they have sclerosis or osteophytes? Sclerosis is like a darkening or a thickening of the bone in those areas. So if you have those features, you have osteoarthritis, and typically there's going to be tenderness on palpation or when you touch the point of the knee where the joint is. Now, there's other things that you can have that mimic osteoarthritis. You can have pain below the knee in the anserine bursa. So if you know where the anserine bursa is and you're the physician and you touch it and it hurts, that person has anserine bursitis. Now, if you're examining somebody's knee and it slides a little bit too much, feeling like it's out of place, they have instability. So what is instability? The instability could be that there's laxity or looseness of a ligament. So there's the lateral ligament, which is the lateral collateral. There's the medial or medial collateral ligament, and there are the cruciate ligaments. The cruciate ligaments, they prevent the knee from sliding front and back, while the collateral ligaments prevent the knee from sliding right and left. So without the ligaments, the knee becomes unstable and the person can fall. And in the conservative way or fashion, you can treat it with a stabilizer brace, as opposed to an osteoarthritic where there's medial joint space narrowing, where you can treat them with what is called a medial compartment offloader. You offload the pressure on the compressed joint. So in the evaluation of the knee, it's not all arthritis, even though I'm an arthritis and a bone doctor. But if we're going to talk about what's common is when you take your history, you have to ask the patient, is there clicking, locking, or giving out? If there are, it could be a ligament or it could be a loose body, which is something perhaps a torn cartilage where there's a piece floating around and it gets stuck as you move your knee. Now, if you don't have any of those features, which are called mechanical signs, if you have no mechanical signs, you start to ask about pain, swelling, tenderness, stiffness, the nature of the pain. Was it acute in onset? Is it chronic? Is it coming on slowly? Did it occur suddenly? Well, if somebody tells me they sprained their ankle in their sleep, they didn't, so they had a crystal attack. What's a crystal attack? Does it mean you got bombarded with diamonds? No. The crystals that we treat are calcium pyrophosphate, monosodium urate, hydroxyapatite. What does this mean in English? to you, the listener, it means gout, pseudo-gout, or basic calcium phosphate arthritis, which would be an attack of hydroxyapatite in a joint. And actually, basic calcium phosphate would typically be the calcium found in rotator cuff tendonitis. So, but back to the knee, because we're dealing with somebody today who had an arthritic knee, which I ended up injecting, and they left feeling a little bit better, and the x-ray did show joint space narrowing with sclerosis and bony overgrowth. That person will then be recommended to go to physical therapy to try to strengthen the muscles of the knee, because as the knee is arthritic, it's not being used properly anymore, and physical therapy for stretching and strengthening, usually by isometrics. You want to do isometrics because you don't have to move the joint. If you've got an already damaged joint or worn out joint, the last thing you want to do is overuse it more. So you try to strengthen the muscles around it, but not by using the joint, rather by tightening the muscles in an isometric fashion. A good example would be, you can strengthen your biceps by doing curls, but you can put your arm in a curled position and hold it there as tight as you can, and you'll get the same result. Maybe not as fast, maybe you won't build as much muscle, but it works. If there are any questions regarding knee pain or osteoarthritis, if you address them to me, within the next few weeks I will try to make another video on this topic, and back to work.